Hey everybody, I'm your four-eyed professor, Chris Lievens, and I'm super excited to talk to you today. Our roll call is for new and experienced ODs, optometry students, and even those just interested in this profession. We'll cover a number of topics together, and I'll help you see them through a professor's eyes. Please take your seats. School's in session. Welcome back, everybody. Thanks for joining us on the podcast today. Well, happy to the springtime. We are going to really go through more of a deep dive into OCT technology. We spent a lot of time last year talking about glaucoma and retina in particular. And, this is still relatively novel technology that's been brought to our fingertips. And now it's become such a commonplace in practice. It's hard to remember where we once were and maybe where we're going, but to make sure that we're all kind of on the same page here. So I'm going to be inviting a guest today that we've seen on the podcast before. This is Dr. Jim Williamson. Thanks, Jim. How are you doing today?
Good. Thanks for having me back, Chris. I always have a lot of fun on these. Appreciate it.
Hey, appreciate that too. So, when did you really start gaining an interest in retina in general? And then when did OCT technology begin to spark your interest?
Oh, Retina for me, obviously during my residency was fantastic. In 97, 98, started to do
Mhm.
a lot of fluorescent angiograms. And then we had a local retina group where the fellow came over and would interpret the angiograms in the room. I was able to listen to their treatments, listen to their thoughts. And that really piqued my interest. Yeah, OCT, we first got in, 2004, I think is when we got our time domain, might have been '03, right around there.
Excellent. Well, I'm going to share a screen of yours, and soon we'll allow you to navigate through this as we start talking about OCT technology. And you and I, being of similar age, it doesn't seem that long ago where we had our visual inspection of the fundus itself, looking at it, inwards, and then the rest of the things that we knew about retina were artistic renderings and occasionally a histology slide.
Yeah, it was amazing when this first came out, time domain. We had never seen the retina like this before. And it really is archaic. Some of these things that you see, up here, you see some little PED right here. This is
Mhm.
a serous detachment. And then you just got some macular edema here. And then this is
Yeah.
what a neovascular membrane looks like right here.
So you mentioned time domain technology, and then now we've fast forwarded into spectral domain and swept source for certain instruments. How do you compare and contrast those to the person that understands what OCT is, but doesn't understand maybe where we've been and where we are?
Yeah, so this is where we are right now. And this is from our spectralis unit. This is a 55-degree image. And yeah, look at the difference. I mean, before with the time domain, it was great because we'd never seen that before. But in certain situations, it was almost like connecting the dots because it was so pixelated. So when you were
Right.
trying to follow these pathologies, it was very difficult. Now, with what we have now, you can see vitreous, you can see retina, you can see down to the choroid. So there's a lot of different things that you can see.
That's a remarkable improvement in
I
imagery.
know it's
Well,
crazy,
I
isn't
mean,
it?
it's really crazy.
Yep, very, very much so.
So how does older technology, besides image quality, or is that maybe that's the main thing, compare from from older to newer?
Yeah, so this is actually a slide of the same patient, believe it or not, from when we had time domain, and then we went and did the spectralis on, so spectral domain, and time domain is was accurate as far as thickness measurements go. I mean, you look at some of the studies that are out there from the Diabetic Retinopathy Clinical Research Network, protocols that they have. Their definition of macular edema is based on time domain OCT, 250 microns. So you still have accurate measurements from that machine, but you can see just in looking at the images are just so much better. You look down here, this is a Brooks membrane opening minimum rim width here. And again, where is Brooks membrane? I mean, yeah, you can see it, but on these images, it's a little bit more difficult to ascertain. The same with up here on the right, you have this near infrared, and I put near infrared readable because, or no infrared readable, because it was. I mean, it was a very difficult image to see. And we know how important it is. And we'll talk here later on in the podcast about your near infrared imaging along with some other things. But your areas were fairly accurate as far as measurements go. Your disc areas, your RNFL, but your clarity of the machine obviously is better, and your
Right.
segmentation of the instrument obviously is much better along with that clarity. So definitely a step up in the way we have now versus what we had back when we were stuck with time domain, which again at the time was really really good.
Sure was.
And we sort of evolved, where before when we got time domain, we were just doing OCTs of the retina and OCTs of the optic nerve. But now, you think about OCTs and what we're using them for. Here's some images of the top images of a patient with episcleritis. You don't think
Hmm.
about doing an OCT on something like this, but if you do an OCT here, you can see the edema is mostly located superficially, versus on the bottom one where you have an image of a scleritis where the edema is much much deeper into the retinal tissue or into the scleral tissue. So that's a nice aspect that you can employ now. Anything you can get light through, you can do in an OCT of. Other disciplines are using OCT technology as well. So you think about skin, some superficial skin things you can do. And you look at here, this is a picture of meibomian glands. And if you do a cross section OCT here, you can see the meibomian glands and their orifices, and because you're getting through that thin layer of skin. So there's other ways that you can do the machine that's evolved over the course of time. Not only the quality of the machine, but also sort of the out of the box uses of it is changed over the course of the years.
This is one of my favorite slides that you just threw up because, where we were once learning layers of the retina, again, from histology slides and from artistic renderings, and now translating that into modern day visualization of OCTs, there are times where I do have to take a step back and remind myself where exactly I'm looking, because typically we're doing these scans of abnormal eyes. And so to try to figure out in an abnormal image where exactly we are, this from the Atlas of OCT is incredibly helpful.
Yeah, if you get on the Heidelberg Business Lounge, I've been using this for years, and this is actually where that image on the bottom right here has come from. You can get a lot of good things. Now, the top one, you think about what they had back then. I mean, they listed major landmarks. You couldn't see anything different in
Right.
that. It just was just one big blur. And so now, you've got the individual layers. And if there's one thing that I can say to all the young practitioners that are out there, is people that are interested, or even the seasoned ones, it's important to know your retinal layers. You can see them now through these spectral domain images. And so you need to know what you're looking at. And if you know what you're looking at and you know what the layers are, and you describe where things have been affected, you can honestly probably come up with a pretty decent diagnosis based on basically what you're seeing. And so, versus just taking a look at the retina as a whole, not teasing out
Right.
the different layers, which you can here. The different cell layers is important to understand. And now we can sort of see where those layers are located with these spectral domain devices.
As we start to talk next about some common errors when you look at retinal anatomy by layer, are there any layers that you found are just so close in presentation to one another that it's easy that it can be confounding to distinguish from one another?
Yeah, when you get loss of tissue, that's hard to ascertain to a certain extent. And of course, when you get pathology disrupts everything. So
Right.
sometimes you get such disorganization. There's something called drill, and we'll talk about that later on. Disorganization of the retinal inner layers, where you can't follow those layers to see. They sort of get all blobbed up into one. So it's difficult sometimes, in significant pathology, to figure out exactly where you're at, what layers have been affected, because everything looks sort of together.
So here's another set of good images that you've thrown up, Jim. So with older technology, again, thinking about where your experience with practitioners, both young and old, as well as some interns and residents, where do you see common errors?
Common, I think segmentation is a big thing. These devices, the new devices do very well with segmentation, but you can get segmentation errors, and we'll talk about that here in another slide or two. But in looking at the retina, I think that some things can be misdiagnosed. If you look at this image over here to the right, this is also
Hmm.
from the Business Lounge, the Atlas of OCT, which actually ironically was on the Instagram page today. But you can see here, this is the Henle nerve fiber layer, and it sort of is mixed. It's in the outer nuclear layer, but in some scans you see it, in some scans you don't, and it's usually the oblique scans that you can see the Henle nerve fiber layer, and that can sort of look different to you. So if you look over here on this side, if you go over to this edge over here, you can see the outer nuclear layer, but over on the right, you can start to see this white fuzz. And this
Mm-hmm.
white area is Henley's nerve fiber layer. It's a little bit of an oblique scan. You can see the RNFL over here is a little bit thicker. So you know that the nerve is over to your left. That's just a way to tell, how you're oriented. So this is on its way to the optic nerve versus this is more of a temporal look.
Right.
But you can see here that, if you didn't know that this was Henley's nerve fiber layer at this location, what else would cause this to occur? Um, you know, acute macular neural retinopathy is located in that area. And, obviously you would take other things into account, but if you're looking at some of your thickness maps, might look at the outer nuclear layer and segment it here, and then all of a sudden segment it down at the bottom, and then it might say, wow, you've got a lot of outer nuclear layer um, uh, basically lost in that area versus what you're seeing there is just handling nerve fiber layer. Down here on the bottom, this little arrow, this is a just sort of a dot that you see. It's sort of a hyper reflective area, and that's completely normal. Sometimes students and residents will look at that and say, what am I seeing here? Am I seeing a little focal epiretinal membrane? But in actuality, that's just sort of a normal finding. And then over to the right, something else that gets confused sometimes in beginners more often than not. But I've also seen this in some patients that have been diagnosed previously as a little serous detachment. But you can see here these photoreceptors, more photoreceptors in your central foveal area than there are elsewhere. And so you can see this outer nuclear layer obviously is a lot larger and thicker. And then down here, you can see the photoreceptor nuclei down here are also thicker because there's so much more in that area. So that can sort of look like, a pathological elevation, but in actuality, it's really not. It's just a normal finding that's there. And those are some of the kind of common things that I see sometimes when residents and students are reading OCTs and what they're looking at, some of the sort of mistakes that they make, and some of the questions they have. They'll come and say, "Hey, Dr. Williamson, what am I looking at here?"
Sure. One of
Here we
the
have.
go ahead.
I'm sorry, Chris. Go ahead.
No, no, it's okay, Jim. Keep going.
Right here we have just wanted to mention just real quick. One time that you were talking earlier about what layers that you're at, you can see here you
Right.
have this substance of tissue. So yeah, so when we have loss of tissue and you start looking across, you're thinking, well, where am I at in here? And basically, again, you just have to remember all the different layers that are there, count them up to a certain extent, and if there's some missing, then you know that you're maybe not where you think you are, and they can help you tease out where things are missing.
Yes, that's exactly what I was going to ask you. So when you're going through an initial review of your OCT and you're thinking about layer segmentation, do you start with the inner retinal layer and then move outward?
Yeah, I tend to. It depends on what I'm looking at. I think the RNFL, obviously, I'm looking more at that nerve fiber layer and how it segments on the Tisnet scans. I think that that's important. And in OCTA pathology, when we're using OCT, and we'll talk about that too here in a little bit. I think that you need to look at segmentation there too, because if you're doing an OCTA, most likely you have pathology that's there, and sometimes the machine gets confused on OCTA, and so that can really be a problem with segmentation when it comes to that sort of pathology. But I tend to look at the retina like most people do, but like here on this slide here, we tend to look at the retina, but what we've sort of lost that fact that these machines can look not only upward, which I'll show you here on the next
Hmm.
slide, but they can also look downward. And I think that that's one of the things that over the years, students and residents will often concentrate on the meat, basically, which is your retina, versus knowing
Hmm.
that you can actually see farther down. And that's one of the nice things about this instrument. When spectral domain first came out, and we were just talking about this. I was up at a meeting in Iowa this last weekend, and we were just talking about this. In the old days, we would take our spectralis and we would push the focus inward, and it would invert that image, and it would turn it upside down, and you were sort of doing
Hmm.
this to see, but you were able to see the choroid so much better. Now we have enhanced depth imaging where you just
Right.
click a button and then that shows you farther down. So that's what these images here just depicting are some images of the choroid, where you can see when you turn on that enhanced depth imaging, you're able to look a lot farther down, and you can see there's a lot of pathologies in the pachychoroid spectrum that have been noted. And you can see here by turning on that EDI, you can definitely see a lot farther down versus
Do,
somewhere here
do
where
you
this
feel like
choroid
you
isn't quite
get
as thick.
do you feel like today you get the same depth on patient A to patient B, or does it vary on your retinas and on your patients and on your scans?
I think to a certain extent it does vary. I mean, obviously, your media to a certain extent, what quality of a scan that you're getting. Yeah, the nice thing for us, especially with our unit, is that you can turn on image summation. So you're sitting there and you art it up, and you can have 100 images that are summated through, and so you can get a really clear scan. And I think that that helps me even on some of those more difficult patients where the media might be optimal. Which a lot of these patients that are older, the media is not optimal, and you've experienced that too when you're trying to look in just with a 78 diopter lens and you're sitting there trying to find that sweet spot. So that's something that can help out.
Sure.
But yeah, over here on the right, just a picture. The optic nerve drusen consortiums come out, and this has been out for a number of years, and basically said that EDI OCT is basically better than a B scan. In my day, and I'm sure yours too, that's how we found optic nerve head drusen, was you
Sure, of
got
course.
out that B scan with 150 microns of resolution, and you're trying to find a 50 micron druse. I don't know, but this is a nice image here of drusen. If you do that enhanced depth imaging over the nerve, you can see these areas of drusen that are popped up. You can see here is a drusen here with this hyper reflective edge and the hypo reflective core. This is a much larger one down here. And with OCT, we've been able to been seeing other things too. This right here is a PHOM. They call it a PHOMS, or parapapillary, hyperreflective ovoid mass-like structure. And these are associated oftentimes with optic nerve drusen too. So we're noting new pathologies. We're noting new things that we can see that we've never been able to see before. With how good these machines have gotten.
Yeah, well, when I try to let people, especially new practitioners, know where we've been, I say, so, we've migrated from our own visual inspection, which we talked about a minute ago, to occasionally having a poor Polaroid image of the retina, to occasionally have a 35 millimeter slide, which was typically 4 to 6 weeks after we saw the patient. Then when OCT technology came about, what you just mentioned, it really kind of looked like a B scan, sonography, where with very little differences in anatomic delineation from one layer to another. And now we really look at what looks to me to be a high definition histology section of the retina, which we're actually seeing in real time and maneuvering throughout the entire retina. It's really quite amazing where we've come in a relatively short period of time.
Yeah, that's a great way to put it, Chris. You're looking directly at live tissue, and so this is obviously this is something that's fantastic. Yeah, we kind of come back to this picture here where,
Mhm.
before we focus down, but you can also focus up. I mean, in the old days, some of the pioneers of Vitreous, how they were able to see different things in the Vitreous, they would put dyes in
Mhm.
cadaver eyes, and they would look at the Vitreous in that way. And now you've got a scan that you can do, and this is a great way to look at your vitreoretinal interface changes using that wide field scan. So it gives you a whole long look at a big area versus your normal, 20-degree scan that's sitting, right around here. And you can see here, you got this posterior precortical vitreous pocket here, and you can actually see the supramacular bursa, which is right here. And then you got this little collector channel, and then the area of Martigini, and then your Cloquet's canal. So all of the students that are out there right now, you are studying this in school. You can actually visualize that using technology that's going to be in your offices.
Right.
When you get out and you start practice, and sometimes the people that have been experienced out there now, pull back that focus just a little bit and get you a good look at that vitreous, and it can really give you a lot of good information.
You mentioned infrared images previously. So when do you use such technologies for your patients, and what other multispectral modalities might you choose for from various patients to various conditions?
Yeah, you mentioned histology, Chris, and I think that's so good because histology people, when they want to look at pathology, they take a sample and they do a stain, right? And so they'll
Right.
do gram stain. An ulcer is gram positive. You can at least narrow your antibiotics down to one or two. The multispectral imaging to me is like a stain that allows us to look at the retina using different wavelengths that'll highlight different areas of the retina.
Hmm.
And most of the machines have this now, and you probably didn't pay too much of attention to it because you're always honed in so much on that OCT scan that you're not looking over at the IR picture that's over there, which is very important, especially now with geographical atrophy being a big topic of conversation with the new drugs that are out there that can treat that. we miss a lot of geographical atrophy by looking either
Mhm.
fundoscopically or by fundus photographs versus these multispectral testing can give us a much better information. And you can see this here. So on the top left here is a nice picture of a fundus autofluorescence, which is around 480. It's actually 486 on this unit here, but you can see these areas that are dark. The dark means that there's loss of tissue. So you're not getting any autofluorescence of anything there because there's no tissue there. And sometimes that can look subtle when you're looking at it fundoscopically. But
Mhm.
obviously,
Right.
when you look at this with this image here, there's no way you're going to miss this. Now, when you get something that's more toward the macula, one of the downfalls of fundus autofluorescence is basically you've got a lot of pigment in the macula, so that pigment's not going to be able to um, transmit through the FAF isn't going to be able to get a signal through that pigment. And you can see here it doesn't look too bad, but then if you complement that with an IR picture, obviously you can see much more damage that's there. And that's the whole great point about multispectral imaging. We think about OCT being tomography only instruments, and that's all we're doing is looking at OCTs, but they have these abilities to be able to do a multispectral picture, and each of those wavelengths will layer different areas. So the blue is more surfacey, your red or green is more middle, and your red is actually beneath to the RPE in the cohort area. So I think that's another thing that we all can use our OCTs for, other than just tomography.
That brings up a question to me that I'd like your opinion on, looking back. So when we first started embracing OCT, and I would say within a few years, it seemed to take over initially our utilization of fluorescein angiography. And now fast forward in time, and I'm seeing a little bit more of a balance again. So it seemed to be all fluorescein when additional testing was needed. Then it was all OCT, and now I'm seeing more of a mix. Are you seeing that as well? And when do you decide to use one versus the other, or both in concert?
I agree with you, Chris. Same thing. We were doing where I work. We were doing probably 15 to 20 angiograms a week. In the early 2000s, and OCT came out, and then yeah, it tanked it to where you were able to get a lot of information just with OCT. But then you're correct. OCT can only do so much. Fluorescein does still have a say. I would say I would do a fluorescein angiogram whenever I wanted to see something that indicated flow. So
Right.
you can get information from an OCT, but it's just a snapshot. It doesn't tell you what is actively going on there. So a fluorescein angiogram obviously will look at flow. OCTA, which we'll talk about here in just a little bit, does give you a look at the vasculature, but it doesn't give you leakage, what's going on in that eye from that standpoint. And so I think that fluoresceins are obviously always going to be part of our practice regimen, but it's just something where the pathology that we used to have to detect it with, we've got another option now, which is less invasive.
So it looks like you have an retinal our NFL picture up here, Jim. What are you trying to show us?
Yeah, so this is what we were talking about earlier when you're looking at the RNFL, when you look at segmentation. And, I made this segmentation up here myself just to kind of give you an idea, what it looks like. But you can see here, all these colored lines are all where the machine has segmented. It's done a great job, and usually it does do a good job of segmenting. But if you do find, especially on your RNFL scans, what's nice about our unit, the Spectralis, is that you can, when you're looking at this RNFL Tisnet, you can give a cursory look to see how well that RNFL has segmented. And again, we were talking about this earlier. When you get to the areas where you see pathology, that machine gets really confused because you can't see the different layers individually, but the machine can't either. So,
Right.
like in this patient, you have so much peripapillary atrophy. Here on the left, you go through this 3.5 ring, and you're catching that area of atrophy. Now, yeah, glaucoma doesn't do a lot nasally, but if that atrophy was over here,
Hmm.
or superior inferior, it might affect what you're seeing. So at least here you can either go to a 4.1 or even a 4.7 ring. That 4.7 ring would get you all the way out past that atrophy, so you can get some usable data on these patients. But I can go back in and I can resegment, and we do that on occasion when we look at the RNFL, depending on what's going on. When the machine doesn't do what we want it to do, we can actually go in and resegment that area and correct it to where it's more accurate. So it's nice being able to take the controls every once in a while.
Yeah, it makes perfect sense.
Yeah.
All right, so now we're at the macula. It wasn't that long ago where, based on patient's chief complaint, their visual acuity, and then uh, the presence or absence of a Watsky-Allen sign was going to delineate how it's going to judge and grade a macular hole with really much, very little else. And so now where have we come in this category of patients?
Yeah, that's funny, Chris, because you were doing the Watts, like how accurate that is the Watsky Allen, and patients understand. Oh
Right,
yeah, you have a full thickness macular hole because of your response.
right.
Gas did a great job of describing these things, and but yeah, now we can just look at the tissue. So, if you look here on the top left, you can see the posterior hyaloid, which is around 100 microns thick, usually 100, 110, but you can see that thickness of the posterior hyaloid. And then over here to the right, this is the same patient through an evolution of an anomalous PVD. So you can see here where you have the vitreous that is separated over here. And again, the RNFL is right here. So this is a more nasal shot of the retina versus over here. You don't see that big of an RNFL layer. So at least you know where your location is. But over here, that vitreous, the posterior hyaloid is still attached in that area. And
Hmm.
then as we go down again, we're able to see this process play out like we've never been able to see it before. You can see here now you're starting to get some separation of the posterior hyaloid from the retinal interface. And this would be more of a broad separation because you still have a lot of attachment there. And as time goes on, you get more separation. And then here you have some VMT or vitreomacular traction, which
Hmm.
basically just means that when you get to the point where that morphology is interrupted, so you get foveal eversion or you get something where you don't have that smooth foveal contour, you've increased to vitreomacular traction disease. And then once you hit to that stage, you keep watching more, and you can see here now that vitreous is all but almost attached, and now
Right.
you have this full blown, posterior vitreous attachment. You see the hyaloid face that's here, and you don't have any retinal sequelae. Now, unfortunately, you can have some retinal sequelae, and you were talking about that earlier, the Watsky-Allen sign, which is what you would do here. Unfortunately, this was the patient's other eye that ended up developing into a full thickness macular
Hmm.
hole. And we measure these, and by measuring, you can sort of at least give an idea on some surgical outcomes and things of that nature. But we're understanding things that we just weren't able to understand before by this technology. And one of the things is, the posterior hyaloid is usually really thick, but it's really thin over the macula, and it's really thin or almost absent over the blood vessels. And that's what happened in this case here, where that vitreous almost has direct connection to the retinal blood vessels, and it actually has avulsed that vessel and pulled it all the way up. So the vitreous really has quite an interaction with the retina that we just didn't see before the advent of OCT, and we'll talk about that here in just a few more slides to see how the interaction is fascinating to look at.
So, hey, Jim, if you had a patient where not on the left side of your screen where we're looking at traction in a hole, but on the right side, you have a patient with a partial PVD that may have some symptoms. Do you have a strategy that you typically employ at how often you repeat their examination and and in this case their OCT to watch this thing take place?
Yeah, I think once they get to the VMT road, I think you need to watch them more closely. I think probably every couple months would be
Yeah.
appropriate.
Okay.
Maybe sooner, depending on what their symptoms are. But yeah,
Right.
you want to make sure you catch them. So I agree, Chris. Just something where you can keep them, just in case something happens. You got them right there. And we had a patient just the other day that over the course, it was just an ERM with just a little bit of traction. And they came back, called actually a month later, and they had symptoms. And yeah, full blown macular hole, full thickness. So it's just one of those things. Educate your patients and try to follow
Right.
them back up so you can catch it, but let that education be your backup. Now, kind of talking about scanning and orientation, I wanted to follow up that slide with just this one right here, where
Mm.
this isn't sort of a play on a scanning protocol, but it's not the machine's fault. The protocol's there, but it's how we use our machines. And I think what's important when you're looking at that fovea, and the best way I can explain this is if you're looking at the fovea, you know, let's say you had a brain tumor, Chris. And I know you're in the medical field too. I am too, and all the people here on the audience that are in the medical
Right.
field. We've all had brain tumors, right? Like everything you're studying, like, man, I think I have that. So, but let's just say that you were concerned about it and you went to have an MRI and the radiologist said, hey, Chris, we think you have a brain tumor. We're going to do 5 scans through your brain and then figure out whether you have a brain tumor. Obviously you wouldn't want that. So I think it's important when you're looking at these foveal conditions to make sure you're doing a dense radial scan through that area because as shown here, if you were just going to do this one horizontal scan here, you might say, yeah, everything looks great. We'll come
Right.
back and see you in a year. But you do radial scan where you get that different orientation. You sort of have a different look to that foveal architecture that you might have missed if you hadn't have done, a different scanning protocol.
All right. This is an interesting image, something relatively common. Walk us through this.
Yeah, so this is ERM. We kind of talked about this before when we see this very, very commonly. And before we just would see cellophane maculopathy, it looked like just a glistening to us, right? But now you have a way to actually look at the tissue and see if what sort of things are going on. ERMs typically are fairly indolent. I mean, they obviously can cause sequelae that need intervention, but most of the times they're fairly indolent. But you can see what it does to the foveal architecture, sort of similar to what a tractional from a VMT would cause, where you get that ectopic interfovea here, where those foveal layers are sort of just shot straight upward. That's here, and then you can see here later on, you get some cystic spaces that can occur in ERMs. And down here, this is called the central bouquet. And of course, you get some changes in that central bouquet too. This is a little Sears detachment that's here. So these are things, before the advent of OCT, bringing our retina to life, so to speak, that we weren't able to
Mhm.
see before. You just were able to see that glistening look to it, and then you just
Right.
assumed that it was an epimacular membrane. And then, now you have something where you can look at all the different layers and see exactly what sort of storm is brewing.
Yeah. When you mentioned that, it occurs to me when I first looked at several patients with ERMs with OCTs, I had no idea what was going on below the surface.
Yeah, exactly. You did. There was no way for you to tell. It just was. It
Mhm.
was difficult. So you didn't have an imaging modality that you could go through.
Okay, now we're looking at some AMD images. It looks like from the ARED study. Now we have OCT as well. Unfortunately, we've had some podcasts on AMD and geographic atrophy in the past year, and it's unfortunate and remarkable how commonplace and how much of a growing concern there is. So, in addition to image comparison, how do we employ OCT to its fullest extent with this ever growing populace of patients?
Yeah, we do. And I think a couple of different points that I can make about this. And, we want these diseases to regress, right? When you see these big drusenoid PEDs and the patient comes back and they look smaller and you think, hey, Mr. X, this is getting better. But unfortunately, it's
Hmm.
not because, eventually when you get progression, you get regression. So,
Yeah.
you eventually as those things dissolve. The second thing I can say is I think one of the areas where this multispectral has really come to play. And you talk about the AREDs with fundus photograph-based pictures are these subretinal drusenoid deposits. They're also called
Mhm.
reticular pseudodrusen. Spade has renamed those SDDs. And this is really important because you see these things are nasty and they'll progress and they always start superiorly, always. And it's because of the density of the photoreceptors is more in elliptical zone is more dense in this area here. So they'll always start superiorly. And as time goes on, these are going to progress and they're going to become areas of geographical atrophy as time goes on. So it's much better now because these are difficult to detect clinically. It's much better
Mhm.
now where you can look at your IR image to the left on your scan, pick these, little guys up, and then you can go over to here and you can see these little subretinal drusenoid deposits, which again, just by the name are above the RPE, they're subretinal versus drusen, drusen are underneath the retina. And as these things go on, you can get subsidence of tissue, areas of geographical atrophy. These are called hyporeflective wedges that you see, just OCT biomarkers. And then on here on our region finder program on the spectralis, you can map the areas of atrophy, and you can see this over the course of time. This disease progressing onward. We talk about it being a degeneration. There's a
Mhm.
reason for that. It degenerates. Over the course of time, it's not going to get better. You look at all the
Right.
AREDS studies; every single one was going up. Even the AREDS 2 formula, you're still going to go up. So.
I'm really glad the way you described your interaction with patients and providers who think that something is getting and looking better. On occasion, we see things improve, but with serious chronic disease, it tends to be a temporary measure at best. And I think we
Yes.
ought to think about not getting our patients' hopes up because, for the most part, the body does not get better with time, and conditions do not get better with time that are chronic. And so, we want to inspire them and encourage them and motivate them. However, false hope is a dangerous path.
Again, Chris, good point. And I think, and I'm guilty of the same thing too. I think optometrists, eye care professionals, are typically, it's hard to give people bad news. It's hard to be quote unquote honest with them. You want to say, oh, you have a touch of macular degeneration versus you don't want to say, hey, you got subretinal drusenoid deposits. These things are really bad. Obviously, you wouldn't word it like that, but you want to be
Right.
honest with them to the point where, hey, this is a picture of a guy over the course of 5 years, or and they went from here to here, and this is where you're
Yeah.
at. So these are the things that I can show you that we need to make some changes, maybe some lifestyle modifications, and be prepared for what possibly could happen down the road.
Even though our topic today isn't going down this path specifically, on a patient like you just showed us, who showed 5 years of progression, which is relatively rapid, were you employing any type of central visual field or manual perimetry to track really function and not just form?
That's interesting. There's been a lot of stuff out there that talk about, you're just looking at pathology through the OCT, but what's their function? What's their contrast sensitivity even? They come
Sure.
in and they read 20/20 on the chart, but then they tell
Hmm.
you I can't see. So yeah, I think that's probably something that we all underutilize, are more of those functional things that we can do with our patients versus just, every 6 months running these OCT scans and just telling the patients, well, you haven't changed, or it has changed a little, but yet they're in their own world having their struggles with their activities of
Right.
daily living. I mean, maybe we could have intervened more had we done more functional testing. So yeah, good point, Chris.
All right. What are we looking at here? I have a hunch, but walk us through this.
I just wanted to show this picture. We're talking about macular degeneration. I think this is just important, and this goes back to knowing your layers very well. This is just a picture of a vitelliform lesion, and on the top there, you can see this vitelliform lesion is hyper autofluorescent. And on a cursory look, you could look at this and call this a drusenoid PED. But really, again, just making sure that you notice where your layers are. You can see that this lesion here is above the retina, so that this
Hmm.
isn't drusenoid. And I think that's
Right.
important. Again, I can't stress that enough, is knowing where you are in the scan, where your anatomy is, and just by describing it to yourself, you can probably come out with a decent diagnosis, most of the time, and at least know what layer of the retina you need to concentrate on.
Do you recall seeing that patient live, and did the fundus appearance appear like it did in the top left?
Yeah, so this the funnest appearance on these usually look, for me, it's usually, lipofusion means dark fat. I think it's a Greek word. So it'll look like a dark pigmented area with a little halo around it sometimes.
Got it.
So it doesn't look as white there. It looks more dark just because of the lipofussion that gets accumulated there.
All right, I see some small vasculature, which typically is never a good thing. So, what are some problems here in this patient, and what are some characteristics of these really nice scans in terms of really looking and trying to manage things like neovascularization?
Yeah, so this sort of brings us all full circle, Chris, because you were talking about fluorescein angiograms earlier, and we mentioned the
Right.
OCTA earlier too. And this is a
Hmm.
patient with macular degeneration, where you see this little, tear in the RPE here, and then you see this shallow, it's called a sire or shallow irregular RPE elevation. And this is very pathognomonic, usually for a macular neovascular membrane. And then you see this subretinal hyperreflective material, which again is just an OCT biomarker, but these biomarkers are important to us when we're looking at these pathologies. And then you tease that out with your OCTA, and you can see here you have this large macular neovascularization that's growing here. Back in the old days, what a nice look you have here on these OCTA instruments. And in the old days, you were doing, the top picture here is a fluorescein angiogram. Fluoresceins were great, but the fluorescein molecule is so small, it seeps through that choroidal vasculature so quick that you get that, choroidal flush. You remember that,
Hmm.
Chris, in your years
Sure.
of watching fluoresceins, you get that flush, versus the ICG molecule or indocyanine green stays in those extravascular spaces longer. And so you can see here, you can see the delineation of a neovascular membrane, but obviously you get a much better look on an OCTA. Now, having said that, you can't see flow again with OCTA, but you can definitely see the architecture of the neovascular membrane forming. So yeah, we've come a long ways. I mean, just being able to do
Mhm.
this quick and dirty, and then you talk about for the ophthalmologists that are out there that are injecting these things,
Mhm.
versus having to do a fluorescein angiogram every time they come back. Let's say
Right.
you have an allergy of dye, and you're having to pre-treat or whatever on these patients, versus doing a quick OCTA, and you can let them know, yeah, the neovascular membrane is shrinking. I'm not seeing as many areas of concern as before. We're going to keep therapy or what have you. So. Very good to be able to employ in those situations.
Agreed. Well, we really can't hit the A through Z's of OCT technology without talking about diabetes, which I pretty much see in almost 100% of my adult patients,
Yeah, it's
and
crazy.
still is an alarming cause of vision loss and adult blindness in the United States, sadly. So,
Yeah,
how do you recommend we employ OCT with this unique patient base that again, like MacDGen, is ever growing?
yeah, and honestly, we should never see these patients with the treatments that are out. You
Right.
shouldn't have to see these diabetic retinopathy patients that are proliferative disease, but they happen, and they happen to us, both of us, all the time. Yeah, OCTA again can really show you these areas of neovascularization that are growing, and here you have this large area where you're not seeing any blood vessels at all. Or you assume there's no blood vessels. The OCTA
Hmm.
has a cutoff, so and you can pretty much make that inference that there's nothing here. All this dropout that's here,
Right.
again, a quick and dirty method to be able to tell you got some neovascularization going on. Down here you can see it just on a regular OCT scan. When you're doing OCT, you can see how neovascularization grows on that interface, retinal surface, and you can see that that's here. One of the tips that I become friends with a guy out of Colorado that works for um, uh, a diabetes center, and he still grades in ETDRS, which I know sounds crazy, doesn't it? Image 47, and I got talking to him. And he had a great point because he was asking, he was answering a question that somebody asked. How do I tell the difference between Neo and you know um, Irma? And he's like,
Right.
Irma will always usually stay within an area. Neo will cross over major blood vessels. And I thought that was a really interesting
Interesting.
thing. I know it was really interesting, wasn't it? And if
Hmm.
you look at it, it almost always is true. I mean, you can see these little, Irma areas maybe that are even up here, but you can see that
Right.
neovascularization is able to cross over. And that makes sense to me because it's growing on the retinal surface. So
Yeah.
um,
I never thought
that
of
was a
that.
good tip. Yeah, it was a really good tip. And some of the other things that we see, even with the stratus, you were able to see macular edema. And we mentioned the DRCR retina network before, but if you look over here, OCT brought us the central subfield, and the central subfield basically is this subfield down here on the right, where it says 444. That's your central subfield, and that's very important for following diabetic macular edema. So if it hits that central subfield, you've got center involved diabetic macular edema. Now, according to some of the studies like Protocol B, if it's over for our spectralis, if it's over 305 for women and 320 for men, then you have clinically significant diabetic macular edema, and obviously that lets you give you some input on how you're going to treat this patient from that Protocol B standpoint. So OCT has done a lot for us on determining these studies and giving us some input on how we would treat these patients that have this macular edema. And you can see here on the top, on the right, you can see this central subfield, and you can just map this out where you've got the 1,000 microns there, and that kind of gives you an idea on where you're at. And I think one other thing you can see about diabetes too is, before clinically when we were looking at diabetes, we would have a patient come in and the patient would not have any microaneurysms or anything else, and we would just say, "Wow, you don't have any diabetic retinopathy." Well, you have diabetic retinopathy before we can see it. We just can't see
True.
it, right? So,
Right.
this patient here in the middle, has pre-diabetes, but when we did an OCTA, you have this inner layer infarct, and these are called diabetic retinal neurodegeneration lesions. And you can see here, this patient obviously is probably already diabetic and does have some changes, but we can't see anything clinically yet. So these instruments are allowing us to see things that, we're able to detect earlier in the process. There's stuff out there on OCTA detecting things before we can clinically see it. So very important.
All right. Well, one of the things I'd like to conclude with and pick your brain on is I would say, and myself included, the vast majority of OCTs we're doing are posterior pole scans, despite its ability to do some anterior seg things, which you mentioned too as well, but even, even peripheral retina angle, what have you. So where can we really push the envelope using this technology as it stands today, and then as we move into the future?
Yeah, so peripheral OCTs have been fantastic. I call them POCTs, where I'm at, just so the technicians know what I'm talking about. And I love to get
Mhm.
behind the instruments and do a live scan. Really, you can sit there with the instrument, and the nice thing about ours with the spectralis, you can swivel it left, right, up, down. I've gotten close to aura on some of these OCT scans before and able to picture some of these things. And it's important to orient your scan right. And you want to orient because there's elevation that you have to deal with in the retina. So
Mhm.
you want to orient your scan right. But you can see these pathologies that, if you look in the retina and you see, this patient has, a full thickness retinal hole, but sometimes when you do a scan over these, there's still some tissue there. So it's not really full thickness,
Right.
versus over here, you see a retinal hole. Now it's got these raised up edges that might make you
Mhm.
think twice about certain things. Same thing over here where you see these schises. And, when you start doing peripheral OCTs, it seems like everybody has a schises, but you're able to see some of these things. I know it's like, okay, it's just another schisis. And then on the bottom right there, you can see an outer retinal hole. And this
Right.
is what they all look like. They all have these big heaped up rolled edges. You have this outer retinal hole, and then you have this schisis detachment that's occurred here. And so, yeah, you're getting an idea of things. And again, there's so much vitreal interaction over that area too. It really will surprise you when you're seeing these things. That top image there above the color photo, what vitreal interaction is going over that area, the traction that occurs. The vitreous is the reason why we have retinal detachment. So,
Right.
that interaction is important, and you can see that interaction on these peripheral OCTs. And I think that's something that is underutilized with practices.
So your image on the bottom right, the outer layer break is beautiful, very clearly evident. Can you visualize inner layer breaks with these species as well?
Yeah, inner breaks aren't as common, but yeah, if you would see an inner break on an OCT, you would obviously have this area here. You would have a
Hmm.
separation here. So an
Yeah,
outer
just
break by
just
itself,
blank space.
yeah, just a blank space. So
Yeah.
an outer layer break by itself is fine. An inner layer break by itself is fine, but an inner and outer layer break is not
Right.
fine because that vitreous thing can go in and fill up that schisis cavity and then get underneath the retina. So, but yeah, inner, and I didn't include one here, but in doing peripheral OCTs, a lot of times you see outer retinal breaks over inner.
Awesome. Well, you really took us on a journey, Jim. I really do appreciate it, and I think it'll resonate with a lot of our experienced practitioners on the podcast today. Any words of wisdom you would give somebody who's just entering this field, or they're on OCT purchase number one, and they're starting scans. Which are the optimal patients to start with, and then when you're looking at a scan for really the first 100 times, how do you develop a comfort level, hoping to get to a mastery of this?
Well, I think one of the big things is whatever instrument you decide on, there's this thing called a user manual, and you've probably heard of it before too, right, Chris?
I have.
Yeah, and I'm guilty too. Sometimes I'm like, oh
Yeah.
yeah, the user manual is right there, but the user manuals really are good resources. The instruments you buy, for us, being with Spectralis, the business lounge is a huge help for going in there,
Hmm.
getting on podcasts like this, but also downloading books and reference materials and things like that where you can see what images they're taking of and can really lead you to help diagnose what you're seeing, and then getting behind the instrument itself and playing around with it, seeing what tools that you have, versus maybe just letting your technicians run the tests, you know get see what sort of things that you can do, your enhanced depth imaging, your different scans, your radial scans, and then whatever protocols you want, whether you want it to scan vertical or horizontal. So I think that that's important to be able to do a hands-on approach versus just letting somebody else sort of be the expert on your device.
I love it. And this is really important stuff. As we've seen just in the last almost 50 minutes, the technology has exploded with our ability to image the retina, as an example. But though we haven't really talked about it, the technology in our medical treatments and interventions for these patient bases have exploded as well. So when we have the technology at our fingertips and the medicines available to patients, it really imposes a expectation on the providers to continue to grow in their knowledge and expertise and their learning with some things which are challenging and can be confounding at times.
Yeah, it's definitely a win-win situation, how OCT is integrated into our practices and our management strategies too. It's been a game changer.
Awesome. Well, thank you again, Dr. Williamson, for joining us. I undoubtedly will have you on again, and we're going to continue our dive into retina because I think due to the technology that we just described, it really is critically important. But so thanks again for joining us, Jim.
Yeah, thanks, Chris. Always enjoy being on here and having a chance to chat. It gets me recharged every time. So thank you.
You got it.
Class is ended for today, and we have no exams or grades approaching. Please email me at foureyeedprofessor@gmail.com if there are topics that you would like to hear and see through a professor's eyes.